So, good morning, everyone. Thank you so much for joining us today in the second day of a 3-day webinar series. And we're delighted to be collaborating with the Pediatric Adolescent Treatment Africa Regional Summit as part of the UNICEF Learning Collaborative. The goals of the Learning Collaborative are really to bring learning from the ground up, to synthesize and share evidence from various partners, facilities, from civil society, and to try to shape policies and improve the HIV response, especially in regards to children and adolescents. So we're really delighted to be collaborating with PATA over these 3 days. And today is the second day of the regional summit, and the overarching theme for today is treatment. So all of the presentations you will hear today focus on how to improve access to treatment for children and adolescents. Before I introduce our presenters, I would like to review some housekeeping issues and logistics. First of all, if you have any technical difficulties or problems hearing, I would recommend that you log in and out of the call or restart your computer. If you continue to have problems, please send me a message and I'll do my best to help you troubleshoot as we are presenting. Also, kindly place all of your microphones on mute while you are not speaking and while the presenters are delivering their presentations. And to do that, you can right-click on your microphone icon, which is next to your name, and select unmute or mute. So without any further ado, I'll introduce our presenters and explain to you the agenda for today. Our first presenter is Dr. Shafiq Kasaji, who is the Deputy Director of the HIV section at UNICEF based in New York. Joining him is Thelma Nkumani from Lumbamba Clinic in Swaziland, who is a nurse working at the clinic. And we have Elawan Suzanne Damani, who is a psychologist at Queen Elizabeth II Hospital in Lesotho. So we are really honored to have them here today to share their presentations and many of the innovative strategies that they're implementing to improve treatment for children and adolescents. So we will hear from them first, and then we will break for some Q&A. If any questions occur to you as you go, feel free to type them in and we will get back to them during the Q&A session. So again, thank you for joining, and I will turn it over to Shafiq, who will give his presentation.
Jessica, thank you very much, and welcome all of you. It's very exciting to be reporting live from the PATA Summit. We wish that you could all be with us to share in the excitement and energy that's here. It's my privilege to present to you some initial introductory slides that seek to provide a little bit of a global perspective on treatment for children and adolescents with HIV, with a strong focus really on community initiatives to try to enhance coverage of treatment and retention in care. So we know that new infections are declining among children. Globally, we've seen a 47% decline since the beginning of the global plan. And of course, the driver behind this has been the scale-up of antiretroviral treatment amongst pregnant women. Pregnant women have gone from being some of the people living with HIV with the lowest rates of ART coverage to coverage rates that are now in excess of 75%. And actually, as a group, pregnant women have the best ART coverage of all people living with HIV. But this success is somewhat varied by geography. In Eastern and Southern Africa, we've seen a 56% decline in new infections, but the decline in Western and Central Africa has been much less significant, with only a 33% reported decrease in that region. And these children are also aging out of the pediatric cohort into adulthood. And so overall, the number of children living with HIV is also declining. And as the epidemic is shifting in terms of numbers, it's also shifting in terms of age. There are fewer and fewer young children and more adolescents living with HIV. So that currently the UNAIDS estimates that at the end of 2016, there were 2.1 million children living with HIV, and more or less equal proportions of those children were in the age bracket of 0 to 4, 5 to 9, and 10 to 14. This represents a very significant shift in the age breakdown of the pediatric epidemic. And if you're seeing these changes in your own clinics and in your own practice and programs, then I think it's a cause for celebration, because it means that the PMTCT efforts at the national level are working, and that clients are growing up on ART, graduating into young adolescence, and eventually graduating into adulthood. So this is definitely good news. But at the same time, we know that pediatric treatment coverage is still too low. At the end of 2016, there were just shy of 1 million children on ART, but that compares to around 15 million adults on ART, which is a coverage rate of 43% versus 54%. And if you look again at the breakdown across the Africa region, Eastern and Southern Africa not only have much higher rates of coverage, they also have much less of a discrepancy between adults and children. Whereas if you look at West and Central Africa, coverage rates for all populations are significantly lower, and the gap between adults and children is significantly wider. The problem that we see is with the youngest and the oldest age group of children. This is data again from UNAIDS, which shows that of the countries that submitted age-specific data, what the breakdown is in terms of coverage for those aged 0 to 4, 5 to 9, 10 to 14, and 15 to 19. And what you can see is that in almost all cases, the band that is in the 0 to 4 age group has the lowest rate of coverage. And in all cases, except for Swaziland, the band that is in the highest age group, 15 to 19, also has a relatively low level of coverage compared to other children. So what are the concrete steps that we as healthcare workers can take to try to address this challenge? The first is to implement treat-all policies for children. Of course, these recommendations have been taken up at national level and have now been translated into national guidelines from the WHO global policy in almost all countries in the region. However, there is an opportunity for clinics that are perhaps not implementing this to get more activated around the initiation of children on ART. And in particular, one key message, next slide, is that there really should be 0 pre-ART kids in clinic registers. Some of us may remember the day when there were pre-ART and ART registers, and if clinics still have children on the books who are in the pre-ART register and who have not graduated into the ART register, then I think it's a priority to identify those children, track them, and bring them back into care. Next slide. The second issue that I wanted to discuss is improvement in linkage to antiretroviral treatment. And this is a great example from the ACT initiative in Tanzania. What this particular project did was to use peers and focal points as individuals to facilitate transition from testing entry points to treatment entry points. So in some cases, these were individuals that actually escorted clients from clinics or hospital testing centers to the treatment programs. And in other cases, there were individuals in the community that were escorting clients identified through testing in the community to the clinic where they could receive treatment. They also, wherever possible, were trying to initiate ART on the same day that the child was brought into the facility. And what you can see is that overall there was a significant increase in the rate of linkage from 71% to over 95% in terms of the children that were identified as positive and newly started on ART. The third issue that I wanted to highlight is the imperative not to delay start wherever possible. This is a slide that is courtesy of Dr. Elizabeth Bimbo in Kenya, and what it illustrates is data from a study undertaken by Dr. Grace John Stewart and her colleagues, which looked at two cohorts of HIV-infected children, infants that were initiated on treatment under 5 months of age, and older children that were initiated on treatment between 1.5 to 5 years. These children were followed over several years of ART, and a battery of neurodevelopmental tests were done at the end of that time to assess cognitive and motor function. And what the table illustrates is that across all neurodevelopmental domains, there were very significant differences in the performance of children that had been started early versus those that had started late. Children that had early ART had superior neurodevelopment, both in terms of cognitive and motor function, and they also had consistently higher CD4 counts compared to those that started after 1.5 years. Excellent. So a number of programs have considered same-day ART start for children and adolescents, and I think this is gaining popularity in treatment programs. And of course, in principle, it's good to initiate treatment as soon as possible after an individual has been identified. But I think it's also important to recognize that hasty treatment initiation is in itself a driver of early loss to follow-up. We've seen this especially in programs for pregnant women and breastfeeding women, where a large proportion of women do not come back following the first visit where they're initiated on ART. And this surely speaks to a lack of appropriate care and attention given to counseling around the importance of ART adherence and staying retained in care. So even as we promote same-day start, and what I've done here is identified some of the enablers and potential barriers to same-day start, we should recognize that, especially in children and adolescents, adequate preparation is important. The emphasis for me is not so much on same-day start versus not same-day start, but ensuring that the process of how to initiate kids on treatment is followed carefully and designed to be able to provide excellent counseling, support for the client, and initiate treatment as rapidly as possible. And this kind of counseling can continue even after treatment has been initiated. So it doesn't have to all happen before the start of treatment. It is a process that can strengthen and reinforce retention in care over the first several weeks of treatment initiation. And then the fifth area that I think merits focus is that of nurse-initiated ART for children. Nurse-initiated ART for adults has been practiced for quite a long time. Pediatric nurse-initiated ART is a relative newcomer. And this example is again from the ACT initiative in Tanzania, where over the course of several years, partners promoted, encouraged, and developed the adoption of a policy, the creation of materials and in-service training, and then a service delivery model that allowed nurses to not only start ART, but draw bloods for viral load testing, manage ART complications, and dispense the drugs. This was, of course, in response to a very severe physician shortage in Tanzania, but it's one that's common to many parts of sub-Saharan Africa. And what the initiative illustrated was that coverage increased from 26% at the end of 2013 to almost double that number of 52% by the end of 2016 when the ACT initiative ended. So this continues to be an important mechanism for improving enrollment of treatment. The sixth issue that I think is worth focusing on is that of integration of TB and HIV diagnosis to identify and link children with HIV onto ART. We've known for a long time that tuberculosis is a significant comorbidity in children living with HIV, and this data from Annika Hessling and colleagues shows that the risk is actually 24 times higher in HIV-infected children compared to those who are uninfected. Next slide. So the ACT initiative in Mozambique sought to try to integrate TB and HIV diagnosis in an attempt to both identify children living with HIV and also ensure that those children made it onto treatment. And what they did was a multi-step initiative which involved training of healthcare workers in the TB sector, cough officers as they're called in Mozambique, on how to do provider-initiated testing for children with HIV. They allocated peer supporters to ensure that positive children were escorted into care and treatment programs, and they developed a tool to capture ART initiation. The results were quite striking. There were, first of all, an increased number of TB patients registered during the reporting period, and a very high uptake of HIV testing within TB clinics. Those patients that were identified as HIV positive were successfully transferred to ART clinics and started on ART, with ART initiation rates in excess of 85% across the quarters of the rollout of the initiative. So a very successful effort to link TB and HIV diagnosis and make sure that co-infected individuals were referred to and started on ART. Before I talk about the seventh and eighth interventions, I wanted to reflect on the issue of retention in care among children. And this is a systematic review that was published in 2016, which pulled a number of papers that reported 12-month ART retention rates. The average retention rate was somewhere between 71 and 95%, depending on where you were looking and when the data came from. But what about rates of virologic suppression? Excellent. This is data, again, from the CDC and the ACT program across 3 countries that looked at viral suppression rates in children that are retained. And remember, these are not those that are lost to follow-up. These are children that are coming back for care. And what they showed was that the failure rate across 3 countries and reasonably large sample sizes was fairly high. Between 31 to 39% of children had detectable viral loads at 12 months on ART. So what drives lower retention? I think these concepts are familiar to many that work in the HIV field. Ryan Phelps put them together in a nice overview paper reported in AIDS in 2013. And what I've highlighted here are those that are really related to a lack of community engagement and attention to client needs that are important drivers of malnutrition. So building upon this, the next slide shows what I think is an important seventh intervention, and this is family-based care. In this model, which is again from the ACT initiative in Mozambique, all family members are seen at the same time and receive a combined package of services, including counseling, testing for HIV, ongoing ART, and lab specimen collection on the same day and at the same time for all members of the family. And what you can see is that over the course of this intervention, there were really significant improvements in retention. the scale on the left is not from 100% to 0. The control group did not have 0 retention at 48 months of follow-up, but the group that had the intervention, which was family-based care, had very significantly improved rates of retention. And this was true for both the children in the families as well as for the adults. So the family-based care model makes sense for everybody in the family. And finally, the 8th set of interventions that I think really are ideas that we need to take up the baton on are community interventions to address challenges. This is an example, again, from the ACT program in Tanzania, where in an attempt to improve retention in care for children, children's clubs were established and peer counselors were identified to both link children into care and also track clients in the community. And between 2015 and 2016, there was a significant uptick in the retention rates from 78% to 87% a year after ART initiation. Next slide shows the same approach, this time applied for adolescents. This was a cohort study reported at the last IAS conference in Paris, which provided community-based support to a large number of clients, adolescents and youth, at 47 facilities in South Africa. And what they showed was significant improvements not only in the loss to follow-up, but actually in the mortality rates as well among those clients that were benefiting from peer-to-peer community-based support mechanisms. And finally, here at the PATA meeting, we've been talking a lot about the intersection between community and the clinic. And this is a document that has not yet been released, but will be released at the AIDS Impact meeting in November, and then again at the ICASA meeting in December. And what this is a toolkit that seeks to provide a comprehensive step-by-step guide on how to implement clinic and community-based organization collaboration. And it takes an approach that's very locally focused. It's not about global connectivity between clinics and community-based organizations, because it's really about identifying local partners that can support and facilitate clinics in the way in which they deliver services. So I'd like to just close by, again, giving a shout out to the UNICEF Learning Collaborative, and also directing people to the excellent and really very rich PEPFAR ACT report, which contains a lot of valuable data and best practices that were identified over the years of the ACT initiative. And finally, many thanks to George Saibury, Nandita Sugandi, Jessica Rodriguez, and my colleagues Nande Puta and Chewe Luo from UNICEF, as well as Dominic Kemps from the Positive Action for Children Foundation. Thank you very much.
Thank you very much, Shafiq. And as I load the next presentation and introduce Elawan, if you have any clarifying questions that you would like to ask, please feel free to type it in. Great. So without further ado, I'd like to introduce Elawan Suzanne Damani, who's a psychologist at Queen Elizabeth II Hospital in Lesotho, and she will be discussing scaling up priority testing and ART initiation. So without further ado, I'll turn it over to Elawan.
Thank you very much, and thank you for having me. I'll be talking about in order to scale up testing for our adolescents. And what we did was to scale up OPT HIV testing and counseling for our adolescents attending the adolescent center to reach 90% of UNAIDS target. We have youth ambassadors who mobilizes the adolescents to come to the center for testing. We do community outreaches. We also sensitize the community through media. We go to the radio to sensitize the community about the center, since the center has just started operating in February 2017. So this was to invite as many adolescents as possible to come to the center. We serve adolescents from the ages of 10 to 24. So what we also did was to scale up index testing, where we started a campaign on where we would ask adolescents to bring their partners and family members for testing and to provide lunch, even transport. We also advise them to bring partners and family members every time they come for when they come for testing. If the adolescent tests positive, we advise and encourage the adolescent to bring the partners for testing. We also conducted trainings on adolescent-friendly services. This was done in a way that in the facility, we want everybody to know about adolescent-friendly services. So we would have trainings for support staff, everyone from the aid, from somebody who's helping us with the cleaning and everything. They should know about adolescent-friendly services, and then we'll scale it up to a clinical staff. We'll have those on-site trainings about adolescent-friendly services so that everybody is equipped and has knowledge about adolescent-friendly services in order to serve our adolescents. We offer test and treat approach, which is same-day out initiative for adolescents who are newly diagnosed with HIV. We have eligible in a sense that for those TB presumptive cases, we don't initiate them immediately, but what we did is to investigate and find out whether they are TB positive or TB negative. And we also provide peer testing for our young adolescents breastfeeding and pregnant. Community, we also do community outreach and linkage into HIV care. In this regard, we collaborated with PSI for testing the community. We normally look at the hotspot where we would find many people, where we find many adolescents, like on the streets in town. We'll have some tests there, and then we will have PSI testing, and then we'll have community nurse initiating our adolescents, and then we will be linked into the facility of choice. We also integrated health services in the form of supermarket approach in our adolescent center. When adolescent comes for health services, we provide HTS, we screen for TB and STIs, we initiate an ad. Should we see that an adolescent has a mental health problem, the adolescent will be seen by a psychologist, or the adolescent, if she or he has social problems, the adolescent will be seen by a social worker. We have AMC and PMC services. We also have weekend clinics, more especially for the peer support groups. We identify adolescents on ad by age, 10 to 14, 15 to 19, and 20 to 24. We divide them by age because we understand that understanding that a 10-year-old will be different from the understanding that a 12, a 20 or 24 years old have. So we have those three types of groups. Adolescents are then called and introduced to the peer support group and encouraged to join the peer support group. If the adolescent is newly diagnosed, and the peer support is introduced to that adolescent, and then they will be asked or encouraged to join the peer support group. We do viral load monitoring and setting treatment goals. Blood is drawn every 6 months after initiation as per the guidelines. So the viral load will be checked, and those whose viral load is not suppressed will have enhanced adherence counseling with those adolescents, and the treatment goals will be set. And we work with our sister clinic, which is LPPA, when dealing with the key populations like commercial commercial sex workers, and they offer a 24-hour clinic providing integrated services. Also, they have moonlight services, and then they have moonlight services where the health worker will mobilize commercial sex workers by joining them in the street at night and encouraging them to test for HIV. The reason we are saying they are joining them is because they don't have to go there as being some kind of, we want information from you that we are investigating, but they need to be part of them. Just like we have mentioned, that by joining them makes them feel more comfortable, and they create a rapport between the healthcare worker and the commercial sex workers. They also have the group counseling and the support groups. Our challenges encountered. Challenges encountered for index and partner testing for adolescents. It's really difficult for adolescents sometimes to come with their partners. The reason is that sometimes they are involved, the partners are more older than them, or sometimes they are involved with married partners. So it becomes a really challenge to bring them for testing. Disclosure is still a challenge for adolescents on art, hence affecting their adherence. You'll find that as young people, they are in a relationship, they want to be loved. Maybe somebody is even the first time for her to be in a relationship, and disclosing the status, they fear that they will be rejected. So it's hard for them to actually disclose their status. For adolescents below 12 years who do not come to health facility with legal guardian or caregiver, they cannot consent for HIV testing as per our guidelines, as they are missed. For the commercial sex workers, the challenge is that they will compromise their refills for the clients. If a sex worker was supposed to go for the refill or anything in her appointment, and then she has a client, she would rather go for the client instead of a refill. So that becomes a challenge since they miss their appointments. We have some successes. We had about 258 adolescents testing in January 2017, but now the number has increased to 609 by August, which makes up to 136% increase of adolescents testing for HIV. We started with about 157 adolescents and young people on ACT in January, but we had about 263 in August, which makes up to 68% increase for ACT patients. And many adolescents on ACT are now joining the peer support groups, which is quite an achievement because they really like being in the groups because here they share the experiences, they share the challenges. You would also find that they engage in more fun activities, and also at the same time they learn because they discuss issues of adherence, disclosure, and so on. We had about just one peer support group consisting of 70 members, and now we have about 4 peer support groups consisting of 25 members per group. Having integrated services at the center and serving adolescents at a convenient time has proven to be one of the successes because the adolescents can come to the center anytime and they are being served as adolescents without being mixed with adults. We have also a dedicated team of health workers. We have an adolescent pediatrician, we have a psychologist, we have 3 nurses, we have social workers, we have 2 professional counselors, we have our youth ambassadors. What we are trying to do here is try to treat adolescents holistically. Should they have any mental problems, then we know that we have a psychologist to attend to that. Should they have any social issues, we know that there will be a social worker who will then link them into the social development ministry. Best practices. When dealing with adolescents in key population, attitude is very vital. Adolescents do not need to be judged. Once they feel that they are being judged, it's like you are saying to the adolescent, go back and never come back to this facility. So attitude is very vital. They need non-judgmental attitude so that they can feel that they are cared for and they are valued. Adolescents also need to be assisted by their peers, someone they can relate with, which is something that all over the summit we have been talking about. For the commercial sex workers, the best practice is to learn them in their work so that one can be acquainted with what they are doing. Then there's trust so that they can access the health services. They need to feel that they are not being discriminated against and that they are part of the community. How these lessons are applicable. It's important to know adolescents are a key the population with high mortality rates, high transmission rates, poor access to health services, and retention on treatment. Commercial sex workers, men having sex with other men and adolescents are key populations with rising HIV infection. Hence, it's important to scale up services for them in order to stop the epidemic. Thank you.
Thank you, Elawan. As we move on to the next presentation, for anyone who has any clarifying questions, feel free to type them in. There are a couple for Shafiq. I don't know, Shafiq, do you want to take them now or to wait for them? There are more specific questions around the interventions that you mentioned. The first one was about the peer counselors in Mozambique. Do you have any more information about the peer counselors that were used as selection criteria and their age, or any more details about the intervention?
Thank you very much for that question. The peer counselor program was part of the ACT initiative, and there is a detailed report on the ACT initiative which does contain more details on the specific program elements that were used for the peer counselors in Mozambique. What I know, peers were used largely as adolescents peers in an attempt to try to ensure that adolescents were better enrolled into care. And peers were also used linked to the TB program to try and ensure that TB clients were successfully linked into care. Mozambique has a long history of peer supporters that have been active members of the health service. They're called activistas, and they're used in a number of different ways as part of the service delivery approach. So in part, I think the ACT initiative built upon that backdrop of strong peer support involvement in the service delivery systems.
And the second question is related. It's from Julia Bishop, who asks, to what extent did community health workers play a role in the interventions you mentioned? You responded to the one about Mozambique, but in the other examples, were they community health workers or working as part of the health system, or more lay counselors or peer educators outside of the health system?
Yeah, this is a great question, because I think there's often confusion around whether what we mean by people in the community. Because quite often there are community health workers that are there and that create that linkage between facility and community, and that's a very valuable and important linkage. But these are health professionals. Often they are district nurses whose role is to serve as health workers within the community. I think what we're exploring here, and what we've heard from many participants at the PATA conference, is a slightly different definition of what community means. It's the community of people living with HIV. So these individuals that I've described in the programs are themselves women living with HIV or adolescents living with HIV who are acting as supporters both in the community and in the facility, but they come from the community of people living with HIV themselves. And I think that adds a different kind of value. It puts a different perspective on the kind of support that they can provide. And especially for adolescents, it really makes a very significant difference between the likelihood of that adolescent engaging in care and taking their treatment versus not.
Thank you, Shafiq. And I think one last question, which is, to what extent do you think that the children being missed from HIV testing and treatment are living in families that are also not reached by MNCH services more generally?
Yeah, I think that's a very important point, there is certainly some truth to the fact that there are individuals that are relatively marginalized, that have worse access, and that the lack of access applies across the family. But if you look at other health statistics that are coming from health programs, what you'll often see is high rates of ANC presentation, especially ANC1, very high rates of immunization, especially DPT1 or BCG immunization rates. So it's not as if these individuals and their families are never coming into health facilities or have no contact with health services. They're getting health services. What we're not doing well is using those opportunities, especially in high burden settings, to also talk about HIV and have a discussion about HIV. So we didn't talk about it much in this particular presentation, but I think there's a lot of value in integrating and lateralizing our responses so that we link other activities within the healthcare system and create a bit more equity around the way in which individuals are accessing different elements of the health services that potentially would be of benefit to them.
Thank you very much, Shafiq. And without further ado, we'll move on to the third and final presentation. The first two presentations really focused on testing and treatment initiation, improving treatment of children living with HIV. And this last presentation will focus on the last 90, which is achieving viral suppression. And it's important that we realize that achieving the last 90 is not an overall average, but we must achieve the last 90 for all populations, including children and adolescents. So I will turn it over to Telma Nkumani, who is from Swaziland, and will be speaking about achieving viral suppression at Lobamba Clinic.
Hi everyone, I've been rightly introduced as Telma from Nkumani. This presentation is related to adolescents within the age group of 10 to 19. That is what our support entails. However, we do cater for people who are between the ages of 8 to 24 if they're still school. What we did and how we did it. The support group was established in January 2016 with 29 children who are meeting on the third Saturday of every month. And then we did healthcare worker capacitation on viral monitoring and management of the portable viral loads, where we had on-site trainings and ongoing mentorship by age-free mentors. And then these mentors provided campaigns and viral load SOPs. And then the clinic appointed a support group champion who ensured that viral load monitoring was done strictly according to the national viral load SOPs. And then we also adjusted iron flow. We extended laboratory hours to enable adolescents to come for blood after school, creating some adolescents for late school holidays so that they do not miss school. And then on adherence support, we provided routine adherence monitoring and adherence control counts for every visit, where we provided small incentives for adolescents that were adhering well, such as sweets or pens or erasers, just to encourage them. On patient empowerment and support, we made sure that we involve everyone who is concerned with the care of the adolescents, like the caregivers and the social workers. The caregivers come to the facility together with the adolescents every quarter, once a quarter, and then they are educated and empowered during support groups and on a one-on-one session, and the caregivers.
Sorry, apologies. I'm sorry. Continue.
And the caregivers, as well as the adolescents, are made to be proactive in viral load monitoring and follow-up of results.
Sorry, I'm trying to adjust the volume. We're trying to adjust the volume to make sure you can hear. Please let us know if it's better.
And then, if you see that as an adolescent that is not acting well due to social issues, we wrote in the social workers so that they may talk to this adolescent in order to improve adherence and thereby subsequently having a non-detectable viral load. And then on fast tracking of patient management for unsuppressed viral load, we collaborated with Babane Government Hospital, which is our mother facility, to appoint reviews for adolescents with adherence or clinical issues and those who are failing on treatment during doctor's outreach visits once a month. Then we have regular clinical and technical support from partners which are AIDS-free. And then we have quarterly data review of viral load monitoring as well as other indicators. Our successes. When we started, we realized that the adolescents, they are not being tested for viral load. So in December 2016, we did a data review where we discovered that out of the 40 that were enrolled, only 10 were non-viral loads and only 5 were suppressed. And then in February, we did another data review. We discovered that out of the 45 that were enrolled, only 35 were non-viral load and 25 were suppressed. And then in May, we discovered that out of the 50 that were enrolled into the support group, only 42 were non-viral load testing and only 38 were suppressed. And finally, in September, we had a total of 55 enrolled in the support group. Out of the 55, all of them were done viral load testing and 51 were suppressed and the 4 were not suppressed. And for the 4 that were not suppressed, we are doing 3 step-up counseling sessions, 1 every month, so that if when we take the viral load test after the 3rd session, if it comes out suppressed, we are happy. If it comes out not suppressed, then we appoint this adolescent to be reviewed by the doctor. Then we have improved disclosure rates. In December 2016, we were at 50%, in February at 67%, in May 80%, and in September at 89%. Another success is that our adolescent support group has transitioned to a treatment group. And then the adolescents and the caregivers are now proactive in viral load monitoring and follow-up, to a point that they even remind us when the adolescents are due for the next viral load test, as well as when the results are not forthcoming, they remind us, they ask us about when the results will be back. Challenges encountered. We had problems, we had staffing issues, like a high staff turnover due to promotions or people seeking greener pastures, and we don't have a resident social worker. We have to refer adolescents who need services of a social worker to our mother facility in Babane. Then on laboratory issues, we have occasional unreliable routine sample transportation, and there's no sample transport on weekends and on holidays, which limits drawing of blood on weekends and holidays. And we have stockouts of laboratory supplies, and then there's long turnaround time for lab viral load results. And then issues on the caregivers and family. Some adolescents have unstable caregivers, and there's poor clinic attendance by some caregivers when called for step-up adherence counseling. And then there's sometimes partial or non-disclosure, causing poor adherence, hence detectable viral load. The best practices. There's regular refresher trainings on viral load monitoring and provision of job aids and viral load SOPs to ensure that the healthcare workers are well capacitated in viral load monitoring. Adolescent support group transitioning to a treatment group, educating adolescents and caregivers on viral load empowers them, encourages them to be proactive in viral load monitoring. Supporting caregivers to provide food disclosure to adolescents. This improves adherence, hence viral load suppression. Doctor outreach support visits from our mother facility, which is Mbabane Government Hospital, and provided fast tracking management of unsuppressed viral loads. After each and every support group meeting, then we give feedback to the multidisciplinary team, particularly on difficult cases that we came across during the support group. And then regular mentorship by AIDS-free mentors. And then we encourage staff to dress casually during the support group meetings so that the adolescents can be able to open up to people who are not seriously dressed in nurses' uniforms. And then we have quarterly data collection to review progress on viral load coverage and suppression, as well as other indicators. How these lessons are applicable. It's a low-cost, high-impact intervention to improve pediatric and adolescent outcomes, which speaks to the third 90. Involvement of all stakeholders who are concerned with the care of the adolescents, such as the caregivers, the social workers, and other community partners for holistic long-term support of the adolescents. And then fast-tracking decision-making and management of unsuppressed viral loads at clinic level, as well as differentiated care model pushing towards the last 90. This one is also helping to decongest the clinic during weekdays because the adolescents then come specifically on the third Saturday of the month to do their to take their pills and for their psychosocial support. Thank you.
Thank you, Thelma, for your great presentation. Please send in any questions. We have about 5 to 10 minutes to take your questions, your comments, any clarifications that you need. And I want to thank all of the presenters because, especially for our last two presenters, they've given the same presentation multiple times today. So they are being very patient and showing such a commitment. I have one question, I think, that for both Thelma and for Eloan, which is you both mentioned how important it was to ensure that the services were adolescent friendly, and there were various approaches you used to do that. Or is there, if you had to choose one, obviously based on impression, because there was no analysis or formal kind of evaluation done, but if you had to choose which of the approaches you used that really were most important for adolescents and to make the services adolescent friendly, what would you say?
Okay, the most important approach I think is the one that we are using when we have the adolescent center, where we know that our adolescents come to the center, they don't have to be mixed with adults. They come as adolescents, they are being self-care, and the time that they stay there, they don't have to queue for very long hours. We know that they are very busy people. If they have to wait for very long hours, we will definitely use them. So having the adolescent center, I think, is the right approach because the services, all the services that they will be getting there are very friendly. And the Saturday services or Saturday or weekend clinics that we are offering, I think, is the best approach for dealing with adolescents because we know that during the day, most of them they are in school, some of them maybe are working at their factories. So the right time will be weekend services.
Thank you.
For the Mama Clinic, it is providing the services in their own space, away from all the other ages, like the adults and the other ages. Friday, Saturday, when they are not at school. It prevents such things as absenteeism, which may prompt the teachers to be asking, why are you so constantly being absent from school? And the adolescent may find himself or herself accidentally disclosing her status to the teacher. So another thing of keeping them within the support group is that in Lopanga Clinic we provide the adolescents with a breakfast, and then later on we provide them with lunch. And as we know, some of them may be from poverty-stricken families. These small incentives that we do for them helps to keep them within the support group, and as well as giving them incentives for those adolescents that are adhering well. It keeps them within the support group.
Great, thank you. And the next question I think builds on your comment, which is, do you have examples of where schools have worked closely with health clinics to tackle stigma faced by adolescents, or have the adolescent support groups worked in collaboration with schools and clinics?
I wouldn't say we collaborating well with schools, but what we do is just to ensure that the adolescents don't come to the clinic during school hours, so that they are not stigmatized or being constantly absent.
Okay, so that's one way, right, to address the stigma. Do you think there's opportunity to strengthen collaboration with schools? Or, and if so, what are some of the barriers to doing that?
Definitely there is opportunity to collaborate with school. But as of now, we are still fighting the stigma battle. So for as long as there's still stigmatization of people living with HIV, it is very difficult to collaborate. The only thing that we can do is to reach out to the schools to give education on HIV-related health matters and other health issues.
Okay, thank you. So if there are no more questions, we'll give you a minute to type in any additional questions. But any comments from our presenters? Any last comments?
Well, there are no comments, but I just wanted to add to more on the school programs that as the adolescent program, we have realized that the best approach that we need to do is to work closely with the schools, because that's where we'll get more adolescents. And maybe we can even have some trainings with the teachers just to ensure that the stigma that the adolescents might be facing at schools is being reduced. So it's something that we really need to take into consideration. We need to partner with the schools more often.
Okay, great.
Okay. As a last comment, I would just like to share the client flow when these adolescents come for a meeting on that Saturday of the month. They come to the facility, the activities is done, when the program is done, and then they go to the nurses who give them their tablets. And then they go out to different sessions where they are separated according to age. The 12 down and the 13 up, they go to separate rooms where they are given information. We have a curriculum for the adolescents on the issues that we need to tackle. They then go to play with the nurses and some of the team members, so that they kind of like open up. They feel free to enter themselves to these individuals because they can play with them. And after that, they have their lunch and they go home.
Okay, great, thank you. And then one last question about, is there engagement of community leaders in adolescent programs?
Yes, we engage community leaders because so if we have a problem of an adolescent that is supposed to come to the clinic, either for a refill or for whatever reason, and we fail to get hold of that adolescent, and the phone numbers that are there. Then we ask the rural health motivators to go to the adolescents' home so that they bring them back to
Lesotho?
Yeah, even in Lesotho, we have the national community linkage coordinators. If we are having the same problem, like we have the adolescents did not come for appointment, when we use the national community linkage coordinators, we know that they are the right people who will help us to bring the adolescent back to the health service.
Just to add on what Lesotho has just said, we also have partner-funded community workers, such as expert clients who are supported by H3, and we also have mental mothers who are supported by M2M, it's mothers to mothers. So they all work as a team together with other community partners like police and partners that are concerned with the care of adolescents and pediatrics.
Okay, great. So I think we're approaching the end of the webinar. So I'd just like to thank all of our presenters sincerely for all of the time put into their presentations and for being here with us. To Dr. Shafika Saji of UNICEF, to Elawan Adamani from Lesotho, and to Thelma Ukumani of Swaziland for being here and sharing all of the lessons that you've learned at your facilities. I think this is a really unique opportunity to hear from what's going on the ground and to hear from all of you practitioners who are tirelessly working to improve treatment for children living with HIV as well as adolescents. So, and thank you all for your great questions. We apologize if you had any difficulty hearing. We will write up a summary of all three webinars, including the responses to the Q&A. So if you had any trouble, you'll be able to refer to that. As well as if you have any follow-up questions, we can put you in touch with the presenters following the webinar. We will also distribute the presentations and the recording. And please stay tuned and spread the word for tomorrow, which is the last day of the webinar, which will focus on caring for children and adolescents living with HIV from a very comprehensive and integrated perspective. So thank you all, and we hope to see you here again tomorrow. And one note, that the webinar tomorrow starts a half an hour earlier, so please note that if you'd like to join or if you're informing our colleagues, due to the schedule of the meeting, we'll start at 8:30 a.m. Eastern Time or at 2:30 Johannesburg time. Okay, thank you.